Hey guys, welcome to another session of Virtual Global Spine Conference. It's my pleasure to have my friend and colleague, Ben Elder from Mayo Clinic, present today on optimization for the practicing spine surgeon in regards to metabolic bone health. So thanks again for being here, Ben, and looking forward to your talk.
Perfect. Yeah, thanks for having me. So this will be an overview of bone health for spine surgeons. So I have some disclosures, but none of them are relevant for this presentation. I'd also like to acknowledge some of my colleagues that I work with regularly in the bone health area, Dr. Ahmad Nasser, Paul Anderson, and Kurt Kennel especially, who have been instrumental in this work. So looking at normal bone remodeling, it's a mix of resorption as well as bone formation, with osteoclasts getting activated and leading to bone resorption, and then primarily osteoblasts laying down new bone and then eventually mineralizing the bone. And for the ideal bone, it's really a nice interaction between these two processes that go on constantly. So I'm looking at osteoporosis. This is really a loss of the microarchitectural structure. So in this image, you see more normal bone at baseline. And then when you have increased resorption increased resorption compared to formation, you end up with osteoporosis and significant bone loss. So bone quality is really multifactorial and dependent on collagen structure, mineralization, turnover, as well as the microarchitecture of bone, as related to shape, orientation, and the interconnectedness of the bone trabecula. Also with the different width, distribution, and porosity of the bone. As you see on these representative images, you have much more solid trabecula here with lower porosity compared to the lower image where you have fairly severe osteoporosis with significant thinning of the trabecula as well as increased porosity. Again, this shows a similar thing of the progression from relatively normal bone to severely osteoporotic bone with, again, significant loss of the trabecular architecture. So osteoporosis is really defined as low bone mass and poor bone quality leading to fragility fractures. In the absence of fragility fractures in patients greater than 50 years of age, it's defined by low bone density based on the Dexa. And this is really a standard compared to a young white woman, and as compared with a T-score of less than or equal to minus 2.5. However, many patients who end up with fragility fractures have a Dexa in the normal or osteopenic range. So it's really not a perfect screening tool. Especially in spine surgery, the Dexa values are typically unusable because they're falsely elevated due to degenerative changes in the spine. So in the absence of other causes of low bone density, what does this really imply? Or if we don't have demonstrated skeletal fragility, in which case a bone density test is not required if you have a demonstration of fragility fractures already, typically at the wrist, vertebral compression fractures, or hip fractures. And so again, you diagnose osteoporosis in postmenopausal women based on T-score, but in premenopausal women and younger men, it's due to low bone mass, skeletal fragility, and in the appropriate clinical context. So what are some of the secondary causes of osteoporosis? So really a lot of the ones we see more commonly are vitamin D deficiency or osteomalacia, multiple myeloma, or other forms of cancer, where we see very significant loss of the bone architecture. Glucocorticoids are a pretty common one, as we see a fair amount of patients with rheumatoid arthritis, and long-term steroids lead to significant bone loss. Some of the other ones are androgen deprivation and aromatase inhibitors. So looking at the spine clinic, a lot of our patients are over age 65. Many may have kyphotic deformities in the thoracic spine from compression fractures, along with a low bone density at the hip. And a lot of patients have a height loss either from deformity or from compression fractures. If there's a 2-inch height loss, there's actually a 4.4 times odds ratio of hip osteoporosis, and that increases to almost tenfold if the height loss is more than 3 inches. Other risk factors are smokers, alcoholics, again, chronic steroid use, a reduced estrogen, and a sedentary lifestyle. But the highest risk population tends to be the thin, white, postmenopausal females of European descent, which we see very commonly in our clinics. So again, in defining osteoporosis, it's either based on fragility fractures or in those over 50, the T-score less than 2.5. About 91% of fragility risk fractures meet the World Health Organization criteria for osteopenia and osteoporosis. And one fragility fracture actually doubles your risk of having an additional one for 10 years. So there's a lot of different ways that we can measure bone fragilities. The most common one are the Dexa derived with the aerial bone mineral density, and then a T-score calculated on that. We also, on the newer ones, can get a trabecular bone score, which really is a measure of the architecture. And then we can also do vertebral fracture assessments to look for compression fractures. FRAX is a newer tool we'll talk about a little later, which is really based on survey questions and multiple factors about the patient, and can be narrowed more with bone mineral density and trabecular bone scoring added to it. And then there's other CT derived ones with quantitative CT or CT bone strength assessments, as well as Hounsfield units. So how does Dexa technology work? So typically it's based on X-ray, in which it's sent to a collimator through the patient and then to a detector. It's very low radiation to the patient, and there's very little scatter radiation to the technologist compared to standard X-ray. It gives you a printout, something like this. This is based on a Dexa in the spine. At least at our institution, we get these printouts where it compares it to normal, low bone mass, and then osteoporosis, and shows where the patient falls on this. And then you get a T-score printout. And again, this is a statistical comparison to young adult 30-year-old females. There's also a Z-score, which is used more commonly for younger men, which is an age-matched control. And so minus 2.5 is the cutoff for osteoporosis, and then -1 to -2.5 is osteopenia. And so this -2.5 was originally chosen so you would have a similar number of people who fall into the osteoporotic range as ones that are predicted to have fractures. And the fracture risk actually doubles. You can see it going up almost exponentially with every standard deviation decrease in the T-score. So a T-score of -5, there's over a 30% risk for fractures. There's also a significant artifact, especially what we see in spine patients with degeneration, vertebral fractures, soft tissue calcification, or overlying objects. And then there's an underestimation in patients with lytic bone disease, prior laminectomies, barium contrast, as well as very small bones. So in addition to Dexa, again, we mentioned the trabecular bone score, which really measures the architecture of bone and is based on the grayscale of the Dexa image. So normal is considered 1.35, partially degraded is 1.2 to 1.35, and degraded is less than 1.2. And so this is really how the trabecular bone scoring works. So this is more normal bone, and you can see it's a fairly uniform pattern as compared to this one, where we see a much more heterogeneous pattern and significant filling defects corresponding to these other areas. And so it's really a measure of bone inhomogeneity. And so really, when we have well-organized bone, it's really putting this lattice structure together, something like the Eiffel Tower, as compared to just a pile of metal that's completely disorganized, as we would see in more osteoporotic bone. And then you can even do finite element modeling based on that to get additional information. The VFA is a test really to look for fragility fractures. So this is a very low radiation image that gives you a snapshot of the spine to look for compression fractures. It has about 1% of the radiation of typical lateral T-spine and L-spine X-rays. About 2/3 of all vertebral column fractures are actually silent, and the patients don't even know about them. But really, all of these that are from a low impact mechanism warrant medical treatment or at least workup for it. And about 40 to 50% of patients with fractures do actually have a T-score greater than -2.5. They'll put them in the osteopenic and normal range. So it's actually the minority that are osteoporotic with these. But they do have a 10 to 20% 1 to 2 year risk of subsequent vertebral column fracture once they have one. And so these are really assessed on the Ganant scale, where grade 1 is 20 to 25% height loss, grade 2 is 25 to 40%, and grade 3 is more than 40% height loss. And again, even in patients with normal bone density, as we see here, once you have one fracture, there's a 10-fold increase in your risk of an additional fracture. And that goes up significantly in the patients with the lowest third of bone mineral density, where there's up to a 25% risk of a second fracture once they have one. And then so FRAX is another measure that we can use for bone fragility, where it's a set of 12 clinical questions that can be asked of each patient. And it's used to determine the risk of fragility fractures over the next 10 years. So you can calculate it three ways. One is just the series of 12 questions alone. You can get more detail if you add in the bone density data, and then even more if you add in trabecular bone scoring along with it. And each of these factors tends to increase your calculated risk. And so your score is reported as a major osteoporotic fracture, or MOF, and it's osteoporotic if this is greater than 20%, or your risk of hip fracture is more than 3%. And you're supposed to use it for a treatment indication, especially when the Dexa is only showing osteopenia. So this is really what the questionnaire looks like, and you plug in the age, sex, weight, height, any prior fractures, familial fractured hips and parents smoking, glucocorticoid use, rheumatoid arthritis, and all the other secondary osteoporosis factors, or elevated alcohol use. And that'll give you a printout like this of major osteoporotic risk of 27% and 10-year hip fracture risk of 17%. And then you can get additional data if you type in the bone mineral density and add in the TBS scoring. And in this case, it went up to 30% and 19%. So this is another measurement of this virtuost, or bone strength assessment, which is based on CT scanning. And so for this, this tends to be a better direct measurement for the spine, but it's not available at all that many institutions. But this is accepted the same as Dexa by insurance companies in order to get patients on treatment. And then other CT-derived ones that we use more commonly are opportunistic Ct for Hounsfield unit measurements. There's typically standardized at L1 vertebral body, and over 150 has been is generally in the normal range, and less than 110 is fairly specific for osteoporosis. The challenge is in the middle range of 110 to 150, you have a clearly significant risk, but it's not as sensitive or specific as the other cutoffs. And you can also use the sagittal recons of the CT to find vertebral column fractures. There's also been some work by Tony Keaveney on the virtual stress testing and doing finite element analysis off of the opportunistic CT scans. So Hounsfield units are a dimensionless unit that's calculated based on the radio density of the tissue, and increased values tend to reflect more dense tissue. Lumbar CTs are commonly obtained preoperatively for our patients, and so it's usually a very easy and costless supplemental measurement. 0 is really the set point of water, and air is minus 1,000. Bone can be as high as 3,000 if it's heavily corticated, such as in the cochlea, but typically in the spine, it runs in the 150 to 300 or 400 range, depending on where in the spine you are. So Hounsfield units less than 110 at the L1 vertebral body, again, has been proposed as a diagnostic threshold for osteoporosis. And it may be particularly useful in patients with degenerative spine issues where the cortical sclerosis will falsely elevate your BMD on Dexa. And so these are very easy measurements to make. So typically you draw a circle or a region of interest, and then most PAC systems will just give you the number based on that region of interest. For manuscripts measuring this, we tend to measure it at the pedicle level, mid-vertebral body, and the inferior aspect of the vertebral body, and average these three together. But we found that they're typically pretty similar, and so you can usually tend to just do it at the pedicle level or even on a mid-sagittal cut, although probably the axial is the easiest to do it on. And so so what's the goal of using all these tools to diagnose someone with osteoporosis? And that's really to get them to qualify for medical treatment before our surgery to try and minimize complications afterwards, and really trying to get them on anabolic therapy to improve their bone density. So what are the different pharmacologic interventions or treatment interventions? So for low bone strength, we have a lot of different medications that we'll talk about a little bit later. Additionally, a lot of these patients tend to be at heavy fall risks, either based on their deformity, prior fractures, or a lot of the other pathology that comes with getting older. And so it's good to refer these patients to PT for resistance training, as well as treatment of fall risk. Nutrition counseling is important. Reviewing their meds for polypharmacy, and which can also contribute to their fall risk or postural hypotension is important. And then hopefully getting them to quit smoking or decrease alcohol consumption, as easy as that is for our patients. So these are a lot of the different medications that tend to be used for treatment. So the main class are bisphosphonates, and there's different variations within these. With oral forms versus IV forms that are administered either every 3 months or yearly. The main side effects we worry about in this population is osteonecrosis of the jaw, as well as atypical femur fractures. There's also the estrogen analogs or SERMs, and those have a risk of thromboembolic disease. Then denosumab is a newer agent that's also used to treat giant cell tumors, and is a rank L inhibitor, which is given subcutaneously every 6 months. And then teraparatide and abaloparatide are parathyroid analogs, which are daily injections for 2 years. And then romosozumab or Evenity is one of the newest medications that's been out for a couple of years now, which is a monthly injection for 1 year, and acts on sclerostin. So again, looking at these, we have the bisphosphonates are really anti-resorptive agents, where they inhibit the osteoclast by binding to the mineralized matrix and getting concentrated in the osteoclast to inhibit formation of the ruffled border. And so really these decrease resorption, but don't really increase new bone formation. Calcitonin is given intranasally and has some effect on osteoclast receptors, again, with inhibition of them. And then denosumab, again, is a rank L inhibitor. And really what it does is prevent the pre-osteoclasts from developing into osteoclasts. And so this is given every 6 months, typically for 5 years. And one of our endocrinologists uses the analogy that it's like you have a kindergarten class of 30 kids, and every year you add another 30 kids to this class, and none of them move on to first grade. And so when you hit 5 years, you have 150 little kids running around. And if you stop the medication, they get all released. There's chaos because you have just tons of brand new osteoclasts that haven't been doing anything for 5 years. So when you stop this medication, you can actually get pretty significant bone loss with it because there's such a rush of osteoclasts. Unfortunately, this one's very easy to give with just 1 injection every 6 months. So I've noticed a lot of primary care and some endocrinologists tend to go to this one more readily because of the ease of administration, getting insurance approval. But it can be very hard to transition to the true anabolics in preparation for surgery once someone's been started on this. And so the estrogen drugs or the SERMs like raloxifene are typically second-line agents. And stimulate some receptors on osteoblasts. And then the anabolics are really teraparatide and abaloparatide, which again are the parathyroid hormone analogs. And these are given daily, 20 micrograms daily for teraparatide and 80 microgram sub-Q for abaloparatide. So it's a pulse dose. And they're the best secondary prevention as they reduce vertebral column fractures by 65%, non-spine fractures by 53%. Then romosozumab or Evenity is the newest, and again, is a sclerostin inhibitor. So this really shows some of the data on teraparatide, and it's used for severe osteoporosis as well as glucocorticoid-induced osteoporosis. And the key thing is once you complete the 2-year treatment of these, you have to transition to a bisphosphonate to maintain the bone you built up, or you can lose it all in about 6 months. And this just shows some of the mechanism of action. So again, these parathyroid analogs act on PTH1R in terms of bone formation, whereas romosozumab is a sclerostin inhibitor that acts in the Wnt signaling pathway in bone turnover. So again, the sequence is very important. So beginning with Prolia or denosumab makes others very difficult. And sometimes what we'll have to do on those is stop them on the denosumab for up to a year and let whatever effect the release of osteoclast has take effect, or 6 months to a year, and then start them on one of the other agents, typically romosozumab. And then again, the anabolics like teraparatide, abaloparatide, and romosozumab, which are used without transitioning to a bisphosphonate afterwards, all effects are typically lost in about 6 months. So in the dosing for the bisphosphonates, they're typically given for 3 years if it's IV, or 5 years if it's oral, and then they get a holiday afterwards with thawing of the Dexa. Denosumab is typically a 5-year treatment with injections every 6 months, and then transition to alendronate again to complete that full 3-year cycle at a minimum, but sometimes lifelong treatment. Teraparatide, again, is given for 2 years and then transition to alendronate, and abaloparatide is similar. And then romosozumab is given for 1 year, followed by transition to ideally alendronate. So bisphosphonates have had some issues with bone healing, particularly in the orthopedic literature, where they found that there are significantly prolonged union times of distal radius fractures. So the data is not perfect on showing that these impair spinal fusion, but there is some evidence to demonstrate it. And again, some of the risk factors are atypical femur fractures or osteonecrosis. But looking at if that bottom orange line is the atypical femur fracture rate, you can see it's a pretty rare complication compared to the number of clinical fractures and hip fractures that are prevented in Asian, white women, and Hispanic women in this manuscript. So looking at the parathyroid analogs, so Forteo was the first one available back in 2002. And again, it has significant reduction in vertebral as well as non-vertebral fractures. And Timlos or abaloparatide is a similar formulation that's been out for about 5 or 6 years now. And this is just comparing the median percent change of baseline and bone density for romosozumab versus teraparatide and the bisphosphonates. You can see romosozumab or Evenity actually has the most significant increase from baseline. So this may actually be the most effective drug we have now, which is one of the newer ones. So we don't have quite as much data yet. And then looking at volumetric bone density, again, we see romosozumab is about the same as teraparatide, but it also has a significant increase in the cortical bone as well. And then what about if patients have been started on another medication first? So romosozumab in the blue line is the patients who are naive to treatment. The green is patients who previously had teraparatide, and the orange is patients who were previously on bisphosphonates. And then the bottom is denosumab. So again, you can see if someone's been treated with denosumab, it significantly limits the potential benefit of romosozumab treatment. And bisphosphonates and teraparatide are slightly lower, but not to the degree that denosumab is. So it's really important to start them on the right medication at the outset. This was a New England Journal randomized trial from 2017 comparing alendronate to romosozumab. And so based on this, for looking at the incidence of new vertebral fractures at 1 year, there was only 4% of patients had new fractures with romosozumab treatment compared to 6% with alendronate. And at 24 months, we see almost a 50% reduction in the risk ratio with romosozumab treatment, followed by transitioning to alendronate at 1 year. Looking at the bone density at the spine, you can see a significant increase, almost 15% by 2 to 3 years of increase in bone mineral density in the lumbar spine, and about 7% at the hip compared to alendronate. So this is clearly a very effective treatment. And now what do some of the literature studies show? So teraparatide is in a study of about 57 patients from Otori, which is one of the few looking at fusion outcomes for teraparatide, found that there's a earlier and more robust fusion in the teraparatide treated group compared to risedronate, another bisphosphonate. In another study comparing teraparatide and bisphosphonates, they gave them therapy for 2 months before surgery and 10 months afterwards, and found that the screw loosening was significantly lower in the teraparatide treated group, and no difference in the control and bisphosphonate groups. This was a retrospective study of 45 patients with at least 6 months of teraparatide treatment following posterolateral lumbar fusion. And they found that the longer duration of teraparatide therapy was associated with higher fusion rates compared to less than 6 months of treatment or bisphosphonate treatment. This was another one where they looked at the insertional torque of patients treated with teraparatide versus those without, who had postmenopausal osteoporosis. And there was a significantly higher insertional torque even after only 1 month of treatment. And then looking at some of the basic science studies, So the intermittent administration of Teraparatide in a rat fusion study with glucocorticoid-induced osteoporosis increased the fusion mass as well as accelerated the time to fusion. Looking at Teraparatide versus calcitonin in a rabbit fusion model, you can see the Teraparatide is the middle bar graph. And so based on manual palpation, CT assessment, as well as histology, Teraparatide had much higher fusion rates than the saline control and calcitonin for all assessments. And then this was a study we did at Hopkins looking at parathyroid hormone and BMP2 in a rabbit fusion model. And there was an increased CT fusion rate in the Teraparatide group versus control, about 75% versus 50%. We looked at different doses of Teraparatide along with low-dose BMP in a follow-up study and found that BMP led to fairly robust fusion rates even at a very low dose, but there is a synergistic effect when combined with the 20 mic dose of Teraparatide and the 40 where we got significantly more bone formation. And so what is really the significance if we look at bone density in our spine fusion patients? So this was a study to look at patients who were undergoing surgery to just see how many patients were osteoporotic and how the Hounsfield units compared to Dexa. And so in this, there's a poor correlation of Hounsfield units with Dexa and degenerative spines, and the Dexa typically overestimated the bone mineral density. In this study, they looked at the prevalence of osteoporosis in patients undergoing lumbar fusion. So they looked at almost 500 patients over age 50 and looked at Dexa and CT-based Hounsfield units and found that the overall rate of osteoporosis in this group was almost 40%. The women were diagnosed more commonly with Dexa, with about 50% of them compared to only 27% based on CT. And patients with lumbar scoliosis actually had a higher rate, with almost 57% of them being osteoporotic. And among the 324 patients that did not have osteoporosis by Dexa, about 26% of that group had osteoporosis if we utilize L1 Hounsfield unit less than 110. This was a recent review looking at the use of opportunistic CT and Hounsfield units in spine surgery. And so they looked at diagnosis of osteoporosis, screw loosening, as well as the impact on fusion and surgical outcomes. And so again, in this study, they found that a Hounsfield units of 110 were similar to a T-score of minus 3.0, whereas the 153 was about the same as a T-score of minus 2. And in this one, Hounsfield units correlated with about 86% of the vertebral column fractures versus only 41% for Dexa. So Dexa clearly does not do a great job at identifying all the patients with osteoporosis. This was a recent meta-analysis looking at the diagnostic accuracy of Hounsfield units compared to Dexa. And based on this, they concluded that Hounsfield units less than 135 were a good screening tool for the detection of osteoporosis, again, where 110 is very specific for osteoporosis. This was a paper we did a couple of years ago looking at osteoporosis in spine surgery patients and what's the best way to diagnose it, or the most comprehensive way that we're going to identify the most patients. And so we worked with the Paul Anderson's group in Wisconsin to combine our patients together. So if we just went by World Health Organization criteria with a T-score less than minus 2.5, we only identified 25% of the patients. If we used a CT Hounsfield units less than 110, we identified 37% of the patients. If we use the NBHA guidelines with T-score criteria, history of a low energy fracture, or FRAX criteria with greater than 3% hip or greater than 20% major osteoporotic fracture risk, then we got up to 75%. And if we combine all these together, we ended up with identifying about 82%. So those seem to be the most sensitive measure. So it's really, you want to do every possible thing to identify patients who may have issues. And does having this bone density information really help us or help predict outcome? So again, this was a review looking at rates of screw loosening. And they found that with patients with screw loosening, if we looked at those with Hounsfield less than 153 in the female population, we found almost all the patients screw loosening compared to less than 187 in the male population. This was a retrospective review of 143 patients who underwent L3 to 5 instrumented fusion. And they found that in the patients who had screw loosening, they had significantly lower Hounsfield units in the L3 vertebral body, the L3 pedicle, as well as the L3 pedicle and vertebral body, including cortical bone. Again, the Hounsfield units, when we look at cortical bone, get significantly higher. This was another study using CT Hounsfield units to look for pedicle screw loosening. And they found that patients with loosening, again, had Hounsfield units around 106 versus an average of 133 in those without loosening. This one had a similar cutoff in another study with 365 patients compared to 2,000 without loosening. And so again, it was about 116 versus 133 as identified cutoff. In this one, they again found a similar cutoff with low 100s versus about 130 was associated with screw loosening. But the Dexa changes did not really see much different between the screw loosening groups. So the Hounsfield unit, again, seems to be a much better predictor of screw loosening than Dexa. And looking at surgical outcomes, these papers show the low Hounsfield unit significantly correlated with fracture after fusion in the adjacent or terminal segment, and the need for revision was correlated to a low Hounsfield unit, but again, not necessarily the Dexa. And so this was a paper we did recently looking at Hounsfield units for patients with osteoporosis-related complications and lumbar spine fusion. So I identified 140 patients over a 7-year period. And interestingly, in the prior version of this paper several years ago, they found when it was just classified by Dexa, they found that patients with osteopenia actually had the highest risk of complications with 40.2% compared to 36% in the osteoporotic group. And so we found that in this group, about 32% of patients overall had an osteoporotic related complication. And as expected, multi-level fusions were associated with more complications. But the multivariable regression analysis showed that only lower Hounsfield units was an independent predictor of osteoporosis-related complications. So again, the osteopenia versus osteoporosis did not make as much of a difference. It was really the Hounsfield. And for every 25-point decrease in Hounsfield units, there was a 1.7-fold increase in complications. This was a paper looking at the association between Hounsfield units and successive fusion, and patients with non-unions had significantly lower Hounsfield units, about 140 versus 200 in those with a solid fusion. This was another paper from Scott Wagner's group, and they found that the average L1 Hounsfield unit was an independent predictor of cage subsidence and T-lifts, again, with about 138 Hounsfield units versus 170 with no subsidence. And there's a similar paper looking at T-lift, and they found that Hounsfield units less than 130 had relatively high sensitivity and specificity for cage subsidence. And this is looking at oblique lumbar interbody fusions, and again, showing that Hounsfield units were a good predictor of this, with those with subsidence having Hounsfield units less than 100 versus about 130 to 140. This is a manuscript looking at laterals out of UCSF, and they found that Hounsfield less than 135 had almost 16 times the likelihood of severe cage subsidence. This is another one looking at T-lifts in patients with osteoporosis of 88 patients, and they found that cage subsidence, iatrogenic fractures, and radiographic complications as expected were more prevalent in the osteoporosis group. And then again, looking at cage subsidence following anterior and posterior stabilization for thoracolumbar fractures. In this study, only patients in the good bone density group maintained their reduction in alignment, which was defined as Hounsfield units above 180. And in ACDFs, we see similar things, where in this paper, both lower Dexa as well as cervical Hounsfield unit scores were correlated with the degree of subsidence. Although the Hounsfield units in the cervical spine tend to be much higher than what we see in the thoracolumbar spine. This was looking at single level ACDF or a single level anterior corpectomy with a titanium mesh cage, and patients with Hounsfield units in the low 300 range compared to almost 400 had much higher subsidence. And then this is a paper we did at Mayo recently looking at subsidence in ACDF, and again we found patients with significant subsidence of more than 2 millimeters had much lower Hounsfield units than those without subsidence or with mild subsidence. And so this was another paper looking at outcomes in deformity surgery. And so unfortunately, anyone who does deformity surgeon has encountered PJK or PJF, which usually is the bane of your existence and requires a significant revision surgery. And so this tends to be a common complication, long segment fusion, with some studies showing almost 50%, although hopefully most of us have gotten it much lower than that. It has significant patient burden with pain, neurologic deficits, disability, and high rate of revision surgery, as well as a significant financial burden with almost $200,000 cost for revision surgery. And so analyzing risk factors and way to avoid these has really become a focus over the last 10 years. So this is a case of mine from about 5 years ago. So as a lady who had a 1-level L4-5 posterolateral fusion without an interbody that was done at an outside hospital about 7 or 8 years earlier. I think they had never obtained any upright x-rays or standing x-rays and identified her deformity, but she had significant pain and deformity-related pain as well as instability pain. So she was found to have a pseudoarthrosis with screw loosening at L4, and then again, a grade 1 to 2 spondylolisthesis was still present. And on her standing films, she had about a 71-degree pelvic incidence and 36-degree lumbar lordosis with pelvic tilt of about 40 degrees and an SVA of 16 centimeters. So you can tell she's bending her knees as well as retroverting her pelvis with a significant sagittal plane deformity. So in this, we did a multi-stage procedure, removing the pseudoarthrosis posterior hardware, and then a 2-level A-lift at L4-5 and L5-S1. In which I got about 48 degrees of lordosis across those 2 segments, and then posterior fixation from L2 to the sacrum, as well as pelvic screws. So unfortunately, on her initial weight-bearing films done about 2 days after surgery, we can already see that there's an L2 fracture. I tried to follow it for a couple of days and see how she would do, because sometimes these will stabilize if it's more of a mild fracture. But she had pretty significant pain with ambulation, so we did a CT scan, and you can see that the entire L2 pedicle basically sheared off and opened up. And so then I revised her up to T10. Again, I tried to undercorrect her just a little bit to try and reduce stress at the top here, but left her SVA at about 6 centimeters and felt that she had pretty reasonable alignment. She's fairly neutral across the thoracolumbar junction and as well as near the UIV. And she did well. And then she came back for her 6-week follow-up, and again has a fairly significant fracture and significant junctional failure at T10. So then we revised her again up to, I think, T2. I put in a little more kyphosis at the top, so probably more than I'd like to see, but to try and take some stress off that and hopefully minimize her risk of doing this again. And she ended up with a small fracture that stabilized at the top and has done well for the past 3 years with this. But looking back with some of the data we know more at this point, looking back at her Hounsfield units, so on the initial one, her Dexa again was minus 0.8 at the hip and minus 0.5 at the radius. So this doesn't even fall in the osteopenic range. This is a normal bone density. But her Hounsfield units at L2 were 68, which is severely osteoporotic. And again, we stopped at the thoracolumbar junction on the second revision with Hounsfield units in the 90s. So looking back, this is someone that clearly needed preoperative optimization with an anabolic therapy to prevent these major complications like this. So we wanted to look at our rates of junctional failure and see if that related to Hounsfield units at the UIV and UIV +1. So we found all patients 50 years of age or older with a UIV between T10 and L2, as well as a preoperative CT encompassing UIV and UIV +1 with a minimum follow-up of 12 months and excluded patients with prior instrumentation at our measured levels. We defined PJK as a change in the junctional angle by at least 10 degrees. And junctional failure as a junctional fracture, fixation failure, or kyphosis requiring extension of the fusion. So we looked at Hounsfield units of the UIV and UIV +1, as well as L3 and L4, and had 2 independent reviewers assess the Hounsfield units in the presence or absence of PJK and PJF. So in patients without PJK, Hounsfield units were about 149 at these junctional levels, whereas those with PJK or PJF, it was about 120, and this was a significant difference. Again, if we group these in the patients with less than 110, we see that this encompasses about 63% of the patients with junctional failure and 56% with PJK, and so significantly higher risk compared to this intermediate group and the group with more normal bone density at the top levels. And based on the multifactorial analysis, the mean Hounsfield at UIV and UIV plus 1 were the only significant findings we had. And so based on the ROC curve analysis, we found the optimal cutoff was 122 for having a risk of PJK or PJF. We then recently repeated this in patients with upper thoracic constructs, which was just accepted in Janus spine. And so again, similar criteria, but looking at patients with a T1 to T6 UIV. And so we measured Hounsfield units to the same areas. So based on this, we also found that Hounsfield units at the UIV and UIV plus 1 were significantly associated with PJK and PJF. And in this one, it was 147 was what we tended to find for those with junctional failure versus 192 and those without. But again, as you get closer to the cervical spine, cervical thoracic junction, the Hounsfield units tend to go up. And this one, we found the optimal cutoff for upper thoracic constructs was 164. And again, in patients with these cutoffs, most of them are going to get found in that less than 145 group. So clearly, Hounsfield units at the UIV and UIV plus 1 are a significant factor with junctional problems. This was another paper from Hanjo Kim looking at junctional issues based on Hounsfield units, and they found that those with PJK had significantly lower Hounsfield units with about 110 versus the no PJK group at 170. And based on their modeling, there's an odds ratio of almost 6 for PJK when the Hounsfield units are less than 120. So if these are predictive of postoperative complications, how can we modify the Hounsfield units? So this was a study that we did looking at the effects of Teraparatide on bone density in the spine based on Hounsfield units and Dexa. So we looked at patients at Mayo with at least 6 months of treatment with Teraparatide and who had a CT and a Dexa scan both before and after therapy. So we identified 52 patients with a mean age of 67 and a mean of about 21 months of treatment with Teraparatide. And so based on this, overall in the lumbar spine, we found a 22% improvement in the Hounsfield units from an average of 110 to 134 with at least 6 months of treatment. But looking at the Dexa scores, there's a significant increase in the lumbar Dexa score, even though this is probably an overestimate of the measurement, but we don't really see much of a change in the femoral Dexa score, which has been shown in some of the bigger clinical trials for looking at medical therapy. So based on this, Teraparatide improved both Hounsfield units and bone density in the lumbar spine, with a minimal change in femoral bone density. And the improvement of Hounsfield units was out of proportion to what we saw of the Dexa results. And what about if we look at different regions of the spine? So 2/3 of your fixation is from the pedicle. And so we wanted to see if there was an effect on the pedicle compared to the vertebral body. So based on this, we looked at different regions of the lumbar lamina, pedicle, and vertebral body, as well as different regions of the sacrum and pelvis where we tend to place our fixation. And so interestingly, we actually had negative Hounsfield units in the sacral ala at S1 and S2. So that has some of the worst bone quality in the body, especially in the osteoporotic patients. And so we found the biggest percent changes were in the S1 vertebral body, the ilium at the S1 level, as well as the S1 vertebral body, and then near the sciatic notch where we try and get our pelvic screws. So it's clearly beneficial for all of our types of fixation that we use. And again, looking at bone mineral density, so there's about a 10% improvement in the lumbar one, but only a 3 to 5% improvement at femoral neck and total hip. So based on this, there is significant regional variation with the lowest Hounsfield units in the sacral ala, as well as the ilium near the sciatic notch. And we saw the largest improvement in the lumbar vertebral body S1, as well as the ilium at the sciatic notch. And so this can really be a helpful adjunct to improve our lumbosacral pelvic fixation. This was one where we looked at how Teraparatide influenced Hounsfield units in different regions of the spine. And so again, we see, so it was beneficial in the thoracic, lumbar, sacral, as well as in the ilium. With about 20 to 30% increase in the Hounsfield units. However, we saw less benefit in the cervical spine but it was also starting at a much higher baseline. So even in the patient with osteoporosis, the Hounsfield units were still about 280 in the cervical spine. And so it's not really clear if there's more cortical bone and that's why they have a less effect at that segment, or it just seems to be less beneficial in the cervical spine. But clearly it seems to be beneficial for most regions of the spine and still had some benefit in the cervical spine. But the lumbar BMD did correlate the best again with our lumbar Hounsfield units. And so these are some of the practice guidelines that have been recently proposed by a big group so they felt that bone health should be considered in every patient prior to undergoing elective spinal reconstruction. And the utility of CT Hounsfield units was specifically mentioned, where if we find a patient with Hounsfield units less than 150, it should trigger a formal bone health assessment. And hopefully trying to identify potential for osteoporosis or other issues that can be corrected prior to surgery. Also, we need to pay attention to vitamin D3 and calcium supplementation. If we do find a patient who's osteoporotic, Forteo and Tymlos, which are the parathyroid hormone analogs, as well as romosozumab or Evenity, are the first-line therapies. Ideally recommended for a minimum of 2 months pre-op and 8 months post-operatively. And Teraparatide was found to improve the Hounsfield units in the lumbar spine in our paper by about 22%. And again, it's critical that an anti-resorptive medication follow the anabolic treatment, which is the bisphosphonates. Otherwise, you're going to lose all the bone you built up over about 6 months. And then Prolia or denosumab or bisphosphonates may be second line in those that don't tolerate the anabolic agents. So that should be the vast minority of patients. Most bisphosphonates and all of the anabolic therapies do decrease the incidence of secondary fractures, and early initiation is critical, as that's the most vulnerable time to have another fracture. Anabolic agents have the fastest onset of action, again, showing some benefit even at a month, and decrease the rates of fracture significantly more than bisphosphonates or vitamin D and calcium alone. And combination therapy has been shown to be more effective, again, with the anabolics for 1 to 2 years, followed by maintenance therapy with bisphosphonate. A lot of spine surgeons, due to risk of bisphosphonates and fracture healing, will avoid their use around fusion surgery, although it's still debatable how much of an effect that has. And Teraparatide and Baloparatide seem to be gaining the widest adoption due to the improved fixation strength, faster bone healing, and higher fusion rates. And again, it's recommended to start at least 6 weeks before surgery and continue to complete the full 2-year course if possible. I tend to want these depending on the extent of the surgery, as well as the severity of their osteoporosis. I like it, but if it's someone with myelopathy, I tend to want at least 3 months of treatment. If I can wait a little longer, 6 to 12 months, and sometimes even up to 18 months with severe osteoporosis and needing a major deformity correction. And then looking at romosozumab, that seems to be a newer one that may be even more effective as an anabolic treatment. But the jury's still out on how this affects fixation and fusion. There was a recently published animal study a few weeks ago showing some benefit in rat fusion surgeries, but the data on it is more limited now. Again, we need to make sure the patients do other measures to reduce risks, such as weight-bearing exercises, smoking cessation, adequate vitamin D3 and calcium, reducing alcohol consumption, stopping medications or decreasing ones associated with bone loss, such as steroids, although that's not always possible in our patients. And after surgery, avoiding flexing through the spine, as well as even beforehand, to decrease their risk of vertebral column fractures. And then physical therapy to increase their extensor muscle strength. Calcium and vitamin D are very important, so they should be getting at least 1,000 to 1,200 milligrams a day of calcium. That's about 300 milligrams in an 8-ounce glass of milk. And usually calcium citrate is better absorbed than calcium carbonate. And also vitamin D3 levels are important to check before surgery. So if they're in that 30 to 50 range, we'll typically start them on 1,000, 2,000 units a day. If it's in the 20 to 30 range, we do 5,000 units per day for 8 to 12 weeks, and then recheck it, and typically continue a lower dose after that. And then if it's deficient at less than 20, again, we'll do a similar treatment and then recheck at that point, but typically have endocrinology evaluate them to make sure that we're not missing something else contributing. And so really, it's important to assess our bone metabolisms, and really we want to maximize the sensitivity and specificity of the diagnosis, as it has a significant effect on bone strength and fixation for our implants, as well as the fusion healing potential. And it's important in patients that need it, in which we can diagnose and detect osteoporosis, to get them on the proper pharmacologic therapy, as there's multiple studies showing improved outcome and decreased complications with these therapies. Again, one of the challenges is that these therapies are very expensive, and sometimes insurance approval can be quite challenging in these patients. And so that's why if we use all the accepted methods rather than just relying on Dexa to diagnose osteoporosis, we can usually get them through, but sometimes it is pretty challenging. We're fortunate that we have a fantastic endocrinology team that takes care of a lot of the legwork in figuring out how to get patients diagnosed and get them started on these medications. But there are some that have terrible Hounsfield units, and even though they don't have formal diagnosis of osteoporosis, it can be challenging to get them started on anything, and it's probably not safe or optimal to offer them surgery unless they can get that corrected. Some of the manufacturers do have more charity programs where if you can't get it approved by insurance, you can apply to the company and they can give you a significantly reduced cost or even free dosing. So really all three of those companies that produce anabolic agents have some variation of that. But even some of these drugs are maybe $10,000 to $20,000 for the dosing, but our surgeries are a lot more expensive than that. And so if we do a complex deformity surgery for $250,000 and then they have junctional failure, it's another $200,000 to $250,000. And if there's even more complications from poor bone density, you could easily get over $1 million of cost around these procedures. So looking at it that way, the cost of these medications is significantly smaller than a lot of the costs that we deal with. But it can be a significant financial hardship for patients. So you really have to work with them closely to figure out the best way to optimize things. So that was a rapid and big overview. So I'd be happy to answer any questions or clarify anything further.
Ben, thanks for that talk. You obviously have a real command on the topic and have a plethora of literature that Mayo Clinic has, that you guys have studied over the last few years. So I personally have a lot of questions. I'm sure Alex and Ali have some questions as well. But one of the questions I have is about where you stop your construct based on Hounsfield units. I know I've heard Jens Chapman from Swedish talk about this in the past, about maybe stopping his construct where the averaging Hounsfield unit is greater than 150. Do you ever make a clinical decision based off of that, or is that something that you're not doing?
Yeah, I always look at that. And so I use a lot of factors. So looking at how higher pelvic incidence, I'll typically be ones that are over 60 to 70 degrees. I'll be more aggressive at going to the upper thoracic spine rather than stopping the lower thoracic. But I tend to look at that. Now, I wouldn't use that to override other biomechanic principles and stop at T8 or T9, where you're getting closer to the apex of the thoracic kyphosis. But if I'm looking at T10 versus T11 or versus L2, then I do look at that. And if I'm on the edge at a lower thoracic versus upper thoracic construct, and the Hounsfield units at T10 and T11 are pretty low, then I'll definitely go up to the upper thoracic spine.
Right. And, Ben, how are you screening these patients? So what patient are you putting through the rigors of a Dexa scan and all these other studies and whatnot? Are you doing like any female over the age of 40 for any type of a spinal fusion, or do you have the age cutoff, maybe a history of vertebral column fractures before? So how do you screen these patients?
Yeah, so in my practice, I don't get too many younger patients who need a one-level ACDF. It's like probably a once a year type of occurrence. So most of my patients are 50 plus, and I do about 60%, 70% of my practice is deformity. So they all tend to be older patients with degenerative deformities. So I get a Dexa on anyone that's undergoing an instrumented fusion, including a one-level ACDF. And we identify a pretty significant number of patients with osteoporosis based on that. And then I also tend to get a CT scan on patients undergoing instrumented fusion as well, just as part of the preoperative workup. More recently, we've started using those CT bone strength assessments more, as those seem to get us. It's kind of merging the Hounsfield units with methodology for diagnosing osteoporosis that's accepted universally by insurance. And so that if we don't get great results on the Dexa, that tends to be a good backup plan. But we've started doing that more commonly, although we're trying to build more throughput with our radiology and endocrinology groups for that.
Ben, what are your thoughts about cement augmented screws in the osteoporotic population? Is this something that you use routinely, maybe at your UIV, or do you not do this routinely?
I don't do it too often. I think for tumors, I think it's fantastic where you have no choice and you have to get something done. But perhaps in a patient with severe myelopathy, you just don't have enough time to wait for full treatment. I think it would be a useful adjunct. But for standard deformity, there's no urgency to these procedures. So I think it's critical to get them optimized first. Now, in some patients who have done full 2 years of treatment and still don't have ideal increase in their Hounsfield units, I think your options are either to not offer surgery or consider cement augmentation.
Hey, Ben, this is Ali. Thank you so much. That was really an excellent and comprehensive review of a very important topic. I got a question for you. Based on all the work that you've done, especially when it comes to analyzing DEXA scans, Hounsfield units, et cetera, why do you think this phenomenon exists where, let's say, a patient who's not osteopenic, right, and then surgically or cannulating the pedicle, and you're like, wow, this guy or this gal really has like poor bone. And then other times where you have somebody with osteopenia, let's just say osteopenia, and you go in there and you're putting screws and you're like, wow, this bone is way stronger than I thought, right? And I know it's very subjective and it's not objective intraoperatively, except with how you feel the insertional torque with your hand and the screws. But why do you think there is that discrepancy sometimes between what you suspect or what you think is the case is going to be, and then what actually happens in surgery? Where's that disconnect coming from?
Well, so I think, so that was actually what started my interest in a lot of this work. Was the person I did my fellowship with, Cal Kabash, was one of the pioneers about 15 years ago, started treating patients with Teraparatide before surgery. And he said he would never retest the Dexa scan afterwards because how the bone felt at surgery was so much better than you would expect. But he never found that the Dexa really changed at all. So he would just give him 12 to 18 months of treatment and then do surgery. And so that's where we started looking at Hounsfield units as a more direct measurement instead. And they seem to have a much closer correlation. And so that's where if we look at Dexa alone, you can take a patient with DISH or ankylosis as an example. So their Dexa T-score, there's a huge amount of cortical bone and osteophytes. So their T-score is going to be positive 3 or 4 and look like it's going to be fantastic bone. But when we look on the CT, it's a cortical shell and then there's nothing else in between. So the pedicle is just complete mush. And so the Hounsfield units seem to do a pretty good job of at least giving us a good estimate of what the bone's going to be like. And that's where I think some of these newer CT bone strength tools are going to be even better with quantitative CT. But the problem is the Hounsfield unit is such an easy thing to get off of any CT scan. Now there's a little variation in the numbers based on which scanner you're using, the distance from the scanner. But overall, everything seemed to average out fairly well. And they're just a good screening tool that we can use. And it takes about 30 seconds to make all these measurements, if that.
Now, Ben, when you state that the lumbar spine has an average Hounsfield unit in a particular patient of, let's say, 132, are you averaging out L1 through the sacrum, or are you just averaging out the vertebral levels, the segments that you're planning to instrument?
I usually look at the ones I'm going to instrument. But again, your goal is trying to find, it's kind of like you want to find the lowest score that's going to get them eligible. So what's the weakest link in your construct going to be? And if one level fails, then your construct has failed. And so if one level has a Hounsfield of 60 and the other are 120, 120s you might get away with in a lot of instances, but not all. But that 60 is going to be problematic. And so it's kind of, you just want to find something that's going to get you the diagnosis of osteoporosis to enable them to get on treatment, because we know that significantly decreases the risk of complications.
Right. Are you ever getting pushback though from the insurance companies if you have a Dexa, like your patient you showed, right? It was negative 0.8, but the Hounsfield unit was like in the toilet, right?
Yeah.
So you have issues with that?
Well, so that's where you want to make sure you're using all your other adjuncts. So looking at Frax is still a completely accepted form by insurance. So Dexa is not the only one that's accepted. So Frax is accepted. TBS scoring can be useful. CT bone strength assessment. If you do the formal QCT analysis, that's accepted by insurance as well. And so that's where the Hounsfield units are good screening, where you may have to go on to additional adjunct tests to try and get that diagnosis of osteoporosis. And just know that it's not only the Dexa. The Dexa is actually not that great it's not very sensitive at picking up all the patients. If they have osteoporosis on Dexa, clearly they have osteoporosis, and it's easy to get things approved. Also, a fragility fracture is a diagnosis of osteoporosis. So looking on your lateral scoli films or your CT, if you see 20% wedging, you can put in your note you have anterior wedging consistent with a vertebral column fracture, which by definition is osteoporosis.
Alex, any questions from you before we wrap up?
No, it was a fantastic talk, Benjamin. Thank you very much. I will recommend it to listen to your talk again once a year. It's so important. It's the most important topic, I think, for the long constructs, for big deformity, but also for a single TLIF surgery. We underestimate the problem, and it's really great. You pointed out all the topics. It was really a great talk. Thank you very much.
Yeah, thanks again, Ben. This was absolutely fantastic. This will be a gold mine of a lecture for years to come in the archives of Virtual Global Spine on YouTube. So I'm not sure who's up for next week. Ali, are you aware who's up?
Dr. Mamagani.
Yeah, I will host the guest from India, and it's Dr. Dipankar Singh, and he will show us his amazing cases we have already seen on social media, and I'm happy to announce him.
Awesome. All right, guys. Well, this will wrap it up. Thanks again, Ben. That was fantastic. And hope you guys all have a great rest of the day.
Thank you.
All right. Take care, guys.